let's move to the third speaker. Our third speaker is J.FERNANDEZ. He leads the liver and digestive ICU of Hospital Clinic in Barcelona. And he will try, because it's difficult, I know, Javier, to answer the question if preoperative sepsis is a contraindication for liver transplantation. Thank you very much.
Hi, Manu. Thank you for inviting me to participate in this symposium, and I will try. We will see if I succeed or not. First slide, please. Next. So this is the agenda that Manu asked me. Global burden of sepsis in cirrhosis, sepsis diagnosis is difficult in these patients, for sure. Is there a specific impact of preoperative sepsis on postoperative outcome in liver transplant patients, besides the impact of their own organ failure? And the last one was, does the impact differ according to the source of infection? There are obviously some open questions here. Okay, next. Global burden, you know. If we analyze general population in the regular ward, cirrhotic patients in the regular ward, 1/3 to 1/4 are either infected or will become infected during hospitalization. And this is even worse in the ICU, 60%. These are data coming from my studies and from the studies of TRE with a survey on liver on ICUs in Europe. Next. Burden, again, this is a sub-analysis of the canonic study. On the left, you are seeing the probability of developing bacterial infection at short term in patients with AD, green line, or ACLF, red line, not infected at admission. As you can see, the risk of developing infection, bacterial infection, as a complication of the syndrome is prohibitive, is huge in ACLF patients, 60% versus 20%. So the burden is huge. And the higher the grade of ACLF, the higher the risk. This is the graph on the right. Next. The second is, it's easy to diagnose sepsis in cirrhosis. Yes. This is still unpublished, and this is not a definitive figure. But this is what we are thinking on saying in the clinical practice guidelines official about ACLF. And what we are proposing in patients with decompensating cirrhosis is that all patients should be submitted, should require a workup, a complete workup regarding bacterial infections, independently of if they present fever or hypothermia, signs of infection or not. White blood cell count is high, low, whatever. You should look for bacterial infections. And obviously, this is even more important in patients with ACLF. Next. Is there a specific impact of preoperative sepsis on postoperative outcome in liver transplantation? For sure. This is hypothetical. This is not demonstrated, but this has been described in some reviews. And what is clear is that we have a narrow window to transplant these patients, ACLF patients. Once they develop sepsis and develop secondary infections, among them fungal infections, the way is closed. So a short window and the preoperative sepsis has an own, for sure. If you are transplanting a patient with an infection, you should be sure that this infection is controlled, but take into account, take in mind that the window for liver transplantation in this patient is very short because of the risk of developing infections at short term of these patients. Next. And is there a specific price? Well, we don't have clear data, but what you can derive from the study of Sundaram in gastroenterology is that patients with vascular or respiratory failure, septic shock of any origin, and probably pneumonia, respiratory failure in this UNOS registry has not sufficient enough granularity and was defined as mechanical ventilation. So I'm not sure about if they are talking about pneumonia. For sure, there are some patients with pneumonia here, but we cannot delineate this. Next, please. Another data that are suggesting that there is a specific impact of sepsis, preoperative sepsis, or preoperative, sorry. And this is the paper published recently talking about a score that identify arterial lactate, so macro and micro circulation and mechanical ventilation as factors associated with poor prognosis. They also identified, I cannot see very well the slide, but I think that this white blood cell count is among these and is not high but low white blood cell count, what is going to lead the patient to poor prognosis. Next. More data. Move. Next, please. Next. Here. No, the pass. Back. This Claire has commented on this very important paper. I think, Manu, congratulations for this, because it's a question that we had in mind always, but nobody put the word in the line. This is again respiratory failure, circulatory failure, and metabolic failure, high lactate levels, in opinion of several experts, impact the prognosis of the patient that can be evaluated for liver transplantation and could be considered, dependently of some scores and thresholds, could be considered as a contraindication for liver transplantation. Next. And here you have the thresholds. These are thresholds for respiratory failure, lower than 150 for norepinephrine. You can discuss 0.5, 1. You will never reach an agreement. And the other is metabolic failure, and you can talk about what is clear is that what is important is delta lactate. If lactate levels are increasing or decreasing, because it's a factor, and the same is with PAFI. The ratio of PaO2 and FiO2. So if it is increasing, we are not going in the right way. If your demands on vasopressors are increasing, you are not going in the right way. Stop. And the same for lactate. Next. And we reach another consensus. Ongoing sepsis and previous infections with pan-drug resistant was considered in this paper, in this survey, in this Delphi survey, or as a contraindication. If you don't have weapons to treat a pan-drug resistant, colonization or infection? Good question, no? There are no bacteria that has no antibiotic therapy right now. Maybe it's difficult, but you have cefidrochol. There are meropenem, avobarbitam. You have more options to treat, even nephrotoxic drugs, but you can do. And what we wrote in this paper was that also, obviously, infections, severe infections, bacteremia, for example, spontaneous bacterial peritonitis, or respiratory tract infections, no bronchitis, but pneumonia, any infection should be treated appropriately. But this severe infection should receive appropriate antimicrobials, at least for 3 days. Can you transplant a patient with SVP? With an active SVP? I have done. Next. For discussion, open questions. Specific impact of MDR. Should it contraindicate liver transplantation? Is there a minimum duration of treatment for sepsis before liver transplantation? Next. I will close the questions, and if you want, we can discuss later, man. All you know that antibiotic resistance is increasing in the general population, also in cirrhosis, and the point is that the pattern of antibiotic resistance differs among geographical areas and among centers. Next. And in this sense, what is key, in our opinion, we will try to demonstrate this in a randomized control trial. But what we are proposing is that you tailor your empirical antibiotic strategies to your local epidemiology. Next. So there is an impact, yes. Many answers question. Chance, hopefully, Thierry will answer many of them, not all. Okay, thank you.
Thank you very much, Javi. Very nice talk. A lot of questions. Thanks because you make my job. You found me some questions for the discussion after. So
I just follow your instructions.